Uh, Mr. Chairman, ladies and gentlemen, first of all, let me thank Dr. Vinod Singhal for inviting me to this excellent meeting. I'm really enjoying Dubai and, of course, the scientific content of the meeting very much. So I'll go directly to the topic I would like to share with you, and the topic I consider as quite important, and that's defining success and failure in bariatric and metabolic surgery. There is nothing to disclose from my side. Yesterday, I've heard a lot of wonderful talks on cancers and cancer surgeries. And what was very interesting to me was to see that the cancer surgeons were talking about tumor recurrence, which is fine, and which happens. They were not talking about procedure failure. However, when there was a talk about bariatric surgery, and there was mentioned weight regain, which to me equals to a certain extent as tumor recurrence, all of us were talking easily about procedure failure, about sleeve gastrectomy failure, about gastric bypass failure. In my opinion, it is not a failure of the procedure, it is the disease recurrence we are facing. So just to put it in this perspective. So in my talk, I would like to touch the topic of the true failures after bariatric surgery, and then about the artificial ones, which were set up by us bariatric surgeons, as well as by the medical community. Sorry. So the objective major failure is, of course, the big problems, including mortality. This is a procedure failure, and that should be stated as that. And as you can see, that bariatric surgery, there was a wonderful review, a literature review published by Buchwald and his co-workers, and the overall mortality, the early mortality after bariatric surgery is about 0.3%, which is well acceptable. Just for a comparison, it's very similar and very close mortality to laparoscopic cholecystectomy performed in non-obese individuals. Very similar results were reported by the Italian group on about more than 13,000 patients. Again, the total mortality of bariatric surgery came to 0.25%, seen from the database in Italy. Looking at other complications, I'm sorry for the quite busy table, but what you can see is that there are some other, let's say, life-threatening complications like perforations and leaks, or small bowel obstruction, and you have seen different presentations on this topic this morning. So those are again true procedure failures. And all of us would agree with that. And this is a table which was published in Canada and US, and you can see that the overall combined serious complications of bariatric surgery go somewhere to less than 3%. I think so that's a very acceptable thing. However, coming now to the artificially set up bars or borderlines where we talk about failure of the procedure. One of them is the body mass index and the body mass index change. I would not blame the man who invented more than 150 years ago the body mass index per se, this Belgian mathematician, and he was very right and correct in setting up the body mass index. However, the body mass index criteria, which we have as an indication criteria for bariatric surgery, they are not reflecting anything because it's a 150 years old index, and as you will see, it has got a lot of flaws. One of the flaws is that there is no gender difference in the body mass index, meaning that the percentage of body fat is totally different and significantly different in men and women, as you can see from this table. All right, so as you can see here, women with body mass index of 35 have significantly higher body fat than men, of about 10%. In our indications, we don't consider that at all. We just go for body mass index 35 plus comorbidities or body mass index of 40. The same thing happens when we refer the results of our treatment. We don't care. We just refer whatever bar we set up as a definition of failure or success, and that's it. So this is one thing. The other thing is the same applies for fat mass and fat-free mass in men and women. You can see that the scissors are even more open in that regard. There is no ethnic criterion, apart from lowering the body mass index as an indication criteria for Asian population, for I think so 2.5 points. There is no other difference. And as you can see, for example, for the hypertension, there is a huge difference among the different ethnical groups. With the same body mass index, you can see that there is a different prevalence of hypertension. The same applies for type 2 diabetes among these ethnic groups. Again, we are reporting the percent of type 2 diabetes resolution, and we are mixing apples and pears. We are not saying, okay, this is pertinent to Asian population, this is pertinent to other different population. We are just reporting our results, and if we are below a certain bar, we say it's a failure of the procedure, but probably it's not. So there is other failures which are linked to patient and scientific community perception of our work as a bariatric surgeons. I realize that once we started many years ago with bariatric surgery, we were pushed by ourselves and by the medical community to set up really a tough criteria for being successful, because bariatric surgery was not accepted as a surgery, as a treatment modality. So we are still referring our success as the change of the excess weight loss, or we are focusing on weight loss per se. And I must say that the physicians were much far ahead from us. I mean the obesity physicians, because they said it's much better to have a fat and fit person rather than have a slim person and unfit person. And I think so that we are focusing too much on weight loss, and we are ignoring, up until the last 5 to 10 years, we are ignoring the effects on comorbidities and metabolic status of the patient. So we are saying, okay, the patient should lose more than 50% of his excess weight to be able to consider the procedure and the patient as a successful. The patient should maintain the weight loss for at least 5, 10, and more plus years. The procedure has to have a low major and minor surgical complication rates, reoperation rates, etc. So probably I would like to show you this slide and just think about what's written there, and I'll show you where this comes from. So this just says that a success of a treatment of obesity is about 10% of weight loss in 1 year, and all of us should keep in mind that a modest weight loss of 5 to 15% in total of the body weight significantly reduces obesity-related health risks. And also it says that realistic goals should be set up for the treatment. So There is an aim to lose 5 to 10% of original weight and to maintain the weight for 6 to 9 months, and after that the 6 and 9 months are losing weight months. Guess where this comes from? It's the nice recommendations for treatment of obesity. I think so that no one would blame NICE to be not up to date. And this is the definition of success of obesity treatment by non-surgical means. What I mean by that, again, is that when the bariatric surgeons and the community of bariatric surgeons set up the bars for 50% of excess weight loss, I mean, we were almost crazy, I should say, because whatever is lower than 50%, we say, oh, it's a failure of the procedure, regardless the patient has got a beautiful metabolic results. There is a resolution or at least substantial improvement of type 2 diabetes, but we blame ourselves. That's a failure of the procedure. Can you imagine that? So, again, the same applies to type 2 diabetes criteria. And, you know, we were saying that the type 2 diabetes remission should be at least achieved in 70% of the patients. It's a nonsense, again. Those are the criteria that are published that when an improvement or remission should be achieved. And I think so those are the criteria that were published in the international guidelines, and I think so that they are realistic ones. And they say that the weight loss should be more than 15%, which I'm pretty fine with that, but it doesn't go to the percent of excess weight loss above 50%, and I think so that even the remission criteria of type 2 diabetes are acceptable. So we should think outside the scale, not inside the limits we set up 50 years plus. So I would like just to summarize that there are, of course, failures of the procedure, which there is no doubt about. Mortality, major complications necessitating emergency reoperations. The other criteria were set up as an artificial ones, and we should consider them and reconsider them, whether they are really applicable for today's life and for today's knowledge of the science. So we should set up realistic criteria and do not preset ourselves for failure from the falsely set up criteria. Thank you very much for your attention. And I would like to use this opportunity to invite you to one of the meetings which is going to be held in the beginning of May this year in Prague. And the meeting is quite exceptional from the point of view that there is, during this meeting, the physicians, obesity physicians and bariatric surgeons are going to meet and discuss a lot of things together. So please, you are more than welcome to come to Prague in the beginning of May. Thank you very much.
Thank you very much, Professor Felix, for this excellent explanation of very important things for us. Thank you. Are there any questions to Professor Fried?
Thank you, Professor Martin, for the lecture. I'd like to thank all the speakers for this nice session. And I just would like to ask about the mini gastric bypass, the success, the failure rates, and the long-term outcomes and the future of this procedure in the bariatric surgery field.
Well, that's a very good question, actually. There is no straightforward answer to that. First of all, I must say that I'm not performing any mini-gastric or omega loop bypasses, whatever you want to call that, so I am not an expert in this field. I think that the so far published results are encouraging, and we should see, I mean, there is already a pretty good number of studies published on this topic as well, again, showing no major problems, quote unquote, with this procedure. I'm far away from being an advocate of that procedure, but I can accept it. And those who are reporting the results are, to me, reliable people from reliable institutions, so I have to believe them. So that's the only thing what I can say about the omega loop or mini gastric bypass.
Thank you. Another question,
I,
please.
in fact, also I thank you for this nice lecture, this nice, you know, different way of looking to the bariatric surgery. But I had a lot of questions and query from your side, which is very logic questions for all of us who are looking for BMIs and bariatric and the procedures. What are the answers for this? What are the criteria you are looking for? Is there any effort over the world to put these criteria to make this disease without recurrence? What's your criteria? I mean, if you're not really on BMI, or
okay,
what are the other things we should look for?
All right, I think so that we should be more ambitious than the conservative treatment is in obesity. So if the conservative treatment says, okay, 5 to 10% is of total body weight loss is sufficient and is excellent result long term, I think so that what you saw and what was published in the guidelines is that if we set up that if a patient loses more than 15% of his total body weight and maintains the weight loss, then I would be pretty successful. I think so that we should also set up the expectations of our patients. What I mean by that is that we are not anymore in majority bariatric, that means obesity or weight loss surgeons. What we are doing is that we are treating the disease holistically. Means that we are more and more focused on metabolic status of the patient and improving his metabolic diseases like hypertension, type 2 diabetes, etc., etc. So I don't care that much about the absolute weight loss of the patient because we are different. And that's more than fine. I'm happy that we are different, not all of us are slim, but I'm more concerned about the hypertension of the patient or type 2 diabetes, which is going to kill him. Not that he is wearing a shirt of XXL. This is not going to kill him. The metabolic diseases are going to kill him prematurely.
Thank you very much. Thank you very much for this statement. I think it's extremely important to point out this word metabolic. This is also why we named the working group within the UAMS metabolic and bariatric surgery.
And the metabolic
first. Metabolic first. And so it's also a good opportunity to again repeat that we have an invitation for this important congress in Prague in May, and we also had the invitation to the IFSO Congress in Vienna in August. So two very important meetings will take place in a very narrow place. It's only 300 kilometers between Prague and Vienna, and this could also be a good opportunity for this new working group within the UMS to work to set up all things that will end up with a board examination of the European Board and with a fellow of the European Board of Surgery / metabolic and bariatric surgery. Thank you very much, Professor.
Thank you very much.